Welcome to Telling the Tooth, the official mental dental podcast. I'm your host, Dr. Ryan Gross, and I'm joined today by my co-host, Dr. Laura Jaycox.
We're really excited to have Jamie on the show today to talk about her experiences as a social worker in dentistry.
Social work in the dental field is something that Laura and I don't know all that much about, to be honest, and it's growing, it's evolving. So when Jamie was available to interview, we thought it was a great opportunity not only for us to learn, but our audience to learn more as well.
Jamie is a really inspiring person who's clearly committed to helping dentists and patients alike with her unique perspective. And since it was something that was unique to our experiences and not something we've learned much about before, we're excited to have Jamie on.
Yes, we are. And with that, I hope you all enjoy the interview. So we are joined by a very special guest today. Jamie Burgess-Flowers joined the UNC-Chapel Hill School of Social Work faculty in 2020 as a clinical assistant professor with a dual faculty appointment at the School of Social Work and the Adams School of Dentistry. She's a graduate of the UNC-Chapel Hill School of Social Work MSW program, where she was a UNC-PrimeCare scholar. Jamie's professional social work experience has been in the healthcare field, addressing health inequities and promoting behavioral health integration in positions ranging from project management to direct clinical practice. In addition to teaching MSW students at the School of Social Work, Jamie also teaches dental and dental hygiene students at the Adams School of Dentistry. Jamie also provides direct patient care at the Adams School of Dentistry as the inaugural social work care coordinator. In this role, Jamie works on an interprofessional team in the student dental clinics, addressing barriers to care to improve patient treatment outcomes and adherence. Jamie, thank you so much for joining us today.
Absolutely. That was a lovely introduction.
Well, great. So I guess we can start with having you talk a little bit more about what you do at the dental school as a social worker.
Yeah, absolutely. So I think it's probably a little bit of a foreign idea to most folks listening to think of a social worker on a dental team. Most people say, "What does that look like?" and "What in the world do you do?" And I really like to explain it in the same way that I explain to my patients, because most of the time when I see a patient, they weren't expecting to see me. They were expecting to come in and have their cavity filled or get their crown. And so when a social worker pops up, that can be a little bit intimidating and a little bit off putting. So I really explain to my patients that my role on the team is to make sure we're addressing every other aspect of your health other than just your oral health. And so that might be emotional health, that might be making sure that a patient is connected with primary care providers and a primary care team. And it might be addressing substance use or other basic needs like housing and food insecurity.
That's great. Where are most other social workers usually positioned?
Not in dentistry. Most social workers that are healthcare social workers historically have been in hospital settings, doing care management, and helping with transitions in and out of the hospital and reducing readmissions rate to the hospitals. A lot of social workers are located in Department of Social Services, working with children and families. Other social workers could be doing completely non-clinical work like policy work and community organizing. We have what we call macro social workers who never do clinical work a day in their career, that are elected officials and running nonprofit organizations. So you can kind of find social workers a little bit of everywhere. There's, I think at this point in time, about over 700,000 social workers working in the United States. So we are kind of everywhere.
Wow.
Oh.
Wow, that's interesting. What has started their entry and your entry into dentistry?
So, historically, with social workers being in hospital settings and primary care, there is a lot of evidence that social workers just work when they're in any type of setting that has to do with healthcare and addressing quality of care, inequities with healthcare, and improving communities as a whole. Because we know when we improve the health of our community, communities improve in many different ways. And so it was kind of a natural next step, I think, for social workers to be in dentistry. With that being said, I'm not the first social worker in dentistry. There are social workers in dental schools across the country. There's about 14 of us who get together once a month and kind of talk about how things are going and programmatic changes and patient cases and fun things like that. But there are some dental schools who have had social workers in their school for 15, 20 plus years. One kind of area of weakness is working on research. And so, even though there's a lot of research and a really good evidence base about social work being effective in medical settings, we just don't have that for dental. And so, until we have that information readily available and a good literature base, it's going to be challenging to be able to create more positions in not just academic settings, but in private practices and community health settings and places like that, kind of the everyday world, as students like to say.
Since dental social work is something new to us and probably most dentists, what are some common myths about social workers that you think are important to dispel?
That is such a great question because I think about, what I'll do is probably frame a question to you all because I'm curious. And I know, Ryan, you've heard a little bit about what I do at the dental school. But before you heard that, when you heard the word social work or the idea of social work, what is the first thing that comes to mind for you? I'm just curious.
My mom is a nurse, and in her professional life, social workers were working with the elderly to find safe living arrangements for them when they would be leaving the nursing home after rehabilitation. So I view them as someone who's working closely with local community resources and family members to try to find a good setting for people to live and function in.
Hmm. I have a friend from college who became a social worker, and I think he works in a rehabilitation center and he helps sick and disabled individuals and advocates for their well being.
Well, that's awesome. So I will say those answers don't probably represent the majority of the answers I would get if I ask dentists about, or any level of dental provider about what they think a social worker does. Most folks who've never, and that shows me you've worked with social workers in some capacity, right? Or you've interacted with a social worker. But the average person, if I were to ask them, what does a social worker do? Most people think of Child Protective Services and they think of the Department of Social Services that Child Protective Services kind of falls underneath. And so there are many times that I will go and talk with a patient and introduce myself. And even with that great introduction that I try to do, that's very all encompassing and whole person care oriented, people will pretty quickly think that I'm there to evaluate their safety. And if children are involved, they're really concerned that I'm there to evaluate the safety of their children. And so that is probably one of the biggest myths is that if you interact with a social worker, that's why they're there, right? Um, and it's sad, but one of the most well-known kind of phrases about social workers is that people think we're baby snatchers. They think that we're coming to take children, and it's so interesting for me to have that reaction from people because I never wanted to be in child protective services. I always knew I wanted to be in healthcare. I always knew I wanted very little to do with pediatrics specifically. I wanted to work with everyone cradle to grave. So that is probably, I would say, the most the largest myth that we face in social work, and it's a huge barrier, and it comes with so much stigma attached to it. The other I think of when it comes to myth is that actually, if you were to ask my family what I do for a living, you probably would have some people say, I think she kind of is like a professional volunteer. And that is totally something that we deal with is people not recognizing that we are degreed, we are educated, and that in various states, you have to have a degree to be considered a social worker in a position where you're called a social worker. And so we, like other professions, have a variety of degrees, but we have bachelor's level, master's level, degrees for social work. We have PhDs, and we have that doctorate level. We also, like myself, folks can become licensed, and so we can be licensed therapists in the state of North Carolina. The most licensed therapist that you would find in rural areas where mental health is really challenging to access, you're going to find a licensed clinical social worker. It's the underpinnings of what we do is work in communities that are more vulnerable, communities that are more underserved. So again, social work is everywhere.
What type of patients do you work with in a dental setting?
So at the dental school specifically, my people tend to be in the student dental clinics because in North Carolina, especially, our student dental clinics are such a safety net for folks coming from all over the state. And so I've worked with patients who live in Black Mountain, which is in the Asheville area. I've worked with patients who are coming from eastern parts of the state that are driving 4 and 5 hours. And so typically, these are patients who are uninsured or underinsured. And we know in the state of North Carolina, if a person doesn't have insurance or doesn't have great insurance, that tends to be tied to employment. And having employment or not tends to be tied to a lot of other social determinants of health, right? So typically, my patient population really lives in the student dental clinic because they are coming to us overdue for dental care or with gaps between dental care because it's pretty pricey even at the student dental clinics. And so a lot of those folks are dealing with unmanaged or untreated mental health issues, longstanding substance use issues. They're missing basic needs that could set them up for better success and better health outcomes. And we've got a lot of folks who are smoking and drinking and other health behaviors that make it difficult, make healing time difficult and make it challenging to be able to reach their dental treatment goals specifically.
Thank you. How do you typically interface with them and how long do those interactions last for? Do you follow up with people or is it more that you refer them to resources at that one visit?
So a big part of my job, which is very, very different from social workers in other settings per se, is that time limitation in the dental setting. We have really long appointments in the dental world, but we take up all of that appointment time, right? So there's not a lot of flexibility to have a social worker pop in and have a really long visit. So one of my goals is to address as much as possible in that one visit. We also know that patients coming from all around the state, there's a high likelihood they may not come back, or it might be a long time before we see them again. So I go in, my goal is to introduce myself and to get the conversation started. So my ask of students before I go in the clinic is, do I have 5 minutes, 10 minutes, or 15 minutes? And I can structure the conversation and the assessment around that, right? So if I've got 3 to 5 minutes, I can do some smoking cessation. There are billable codes out there that are used in the medical world for 3 to 5 minutes for a primary care provider to do smoking cessation counseling. I can do smoking cessation counseling in 3 to 5 minutes as well. If I've got 15 minutes, we might be able to dive into a little bit more. We might be able to go ahead and I can print off information and hand it to them that day before they leave. But if we're really time limited, I get the conversation started. We follow up by phone. And for pretty much all of our patients, I'm going to be following up because a big part of referring a patient or providing information, trying to get them in the right direction in their communities is follow up. It's checking back to say, hey, when you called or when you went in person to go access this service, did they actually answer the door? Did they answer the phone? Were you able to get services? Places close, places that our patients reach out to sometimes don't provide great customer service or don't provide the services that we were looking for. So it's a constant continued conversation. We might pick back up at future follow up visits. We just kind of keep that relationship going, and the door's always open because patients kind of end up with continued needs. It's usually not just kind of a one and done.
In terms of smoking cessation specifically, do you have any models that you follow for structuring those conversations, whether that be the CARES model or motivational interviewing? Do you have any strategies that you like to employ with those kinds of patients?
So yeah, so I think if you have ever looked up a therapist before, you'll see like their modalities that they use listed. And my favorite of all time is eclectic, because that's what I think of for myself. Is there's all these wonderful acronyms and models of care and things that are promoted and we learn through school and informal trainings. And then when it comes to the real world, we just kind of do this mashup of whatever feels natural and what makes sense for us and what makes sense for that patient. And I will say that I lean on motivational interviewing 150% of the time. I think it is the most flexible, um, for lack of better words, model of care or modality that can be utilized. It's something that I find with patients who aren't expecting to talk about it that day and who maybe haven't thought about it in a while. It tends to work best because we learn about really how to just present that idea to a patient in a very laid back, unassuming way and open the door to that conversation and really help them think about the whys and the why nots of cutting back or quitting. And patients usually think we're going to come in with, hey, you need, as a provider and authority, I looked at your chart, it says you smoke, if you're still smoking you need to quit, and here's all the reasons why you need to quit. Motivational interviewing takes a completely different approach. We can even sit there and have a conversation about all of the reasons you love to smoke. It's one of my favorite questions to ask patients is, why do you love to smoke? What do you love about it? And they're like, okay, well, it's stress relieving and it's my, shining moment at the end of a really long, stressful day at work. And we get to have those conversations to really think about, on one hand, what do we love? And on the other hand, how is our life really sucking right now because of smoking?
Great, thanks. That's really helpful.
You had mentioned that you can bill for the code for talking about smoking cessation with the patient. What is the financial model for having social workers in a dental clinic? How is that financially sustainable?
A great question, because this is one of the biggest challenges of growing social work in dentistry. So you're thinking about, social work is thought of, social work in healthcare in general, regardless of the setting, we are thought of as an income saving, a cost saving service. We are not a cost generating service or an income generating service. And so showing that that works is really hard when we're still in a world of healthcare that's not value based. We're not looking at necessarily quality and value over how much money is being made. So right now, in the United States, we don't have a payment mechanism or a billing mechanism for social work and dentistry. It wasn't that long ago that Medicaid started finding ways to reimburse for social workers and other behavioral health clinicians in primary care. And there's a lot of ways that I could see in the future we adapt that Medicaid policy for the dental world. And I think there is a reality where there's a lot of evidence that backs that up. We're also in the middle of Medicaid transformation and all of these wonderful things happening where we're going to start seeing more value-based healthcare. Um, but as of right now, dentistry is not really a part of that. So we're kind of in a really weird place for figuring out how do we show that social work is actually making an impact. Do we show that by value? Do we show that by numbers of, hey, we could be billing for this much? And what I can say is I track everything. I'm looking at, when I am tracking my patient encounters, I'm looking at the value of my patient encounters and the quality of care that it adds and the value to the treatment plan. And I'm also looking at the fact that I spent 16 minutes with a person and I could bill a CPT code for that in an ideal world, which I would have been able to do if I was in primary care. So it's a balance, and it's like it's a little bit of walking a tightrope for how to prove value.
It's really interesting. It seems like it ties back to what you were saying earlier about the need to do research on social work and dentistry. What type of research questions are the most important ones to answer first?
Exactly, exactly. And what's interesting is we have had, even though we have social workers that I've connected with who have been in university settings for 15 or 20 years, most of the time we're clinicians, we're not researchers. We have our licensed our clinical license, as clinicians, but we're not PhDs. We didn't do formal research training. And so that is a huge growth area. And I'm really lucky because I was hired by someone who is a macro heavy research social worker at the UNC School of Social Work. And so one of our goals is to work together to pair our research skills and our clinical skills to be able to figure that out and figure out what are the questions we should be asking, what is the research that we should be conducting, because we've been doing this for a long time in university settings where research is happening, but folks aren't generating the research. They're doing the patient care, and that's what their focus is on.
Thank you.
I guess we could jump into maybe some scenarios or case examples if you want to talk through those to help our audience understand what a day in your shoes might look like.
Yeah, absolutely. Often tell people that my favorite part of my job is that every day looks a little bit different. Again, I think about any day could involve working on basic needs, helping folks address mental health and substance use, working on health behaviors. There's a crisis element to what I do too, so there's some putting fires out. Um, when I think about helpful scenarios that help people think about what I do and kind of put a real look on things. Today is a great example. Earlier today, I was on my third phone call with the patient. Unfortunately, I'm only English speaking. I don't have any other languages under my belt. So I'm often using interpretation services with our patients. And someone in one of our clinics reached out to me from our pediatric clinic and said, I've got this child who's only 7, and for some reason they don't have Medicaid. And I've talked to their grandmother and don't really quite understand there. It sounds like maybe there's some paperwork or documentation issues. Can you reach out and just see what the barriers are? And so with the help of an interpreter, I reached out to grandma, and it was a great moment for myself of remembering that I don't know everything. And as a social worker, sometimes people think we're an encyclopedia of resources and understanding how systems work in North Carolina. And one thing people forget is it's always changing. So even if I was the expert in Medicaid, tomorrow some policy would change and I would already be outdated. um, so I had to just kind of hit the Google, and I had to go to work and figure out by talking with grandma that unfortunately, she was ready to apply for Medicaid for her grandkids, but they were born outside of the states. And a part of Medicaid, you have to have a social security number, at least in North Carolina. And so she went down the trail of getting social security numbers, and you have to have documents on documents on documents to be able to prove your identity, your age, and all of these different elements to get a social. And she had everything except for the original birth certificates. She had copies. So she waited a month for her visit with the Social Security office. She shows up and she has everything but one document. So talk about starting back at square one and wanting to just kind of throw in the towel. I think that's where grandma was at. So when we talked, I learned about Medicaid eligibility. I learned about how to get a social security number. I called government agencies and had a horrible experience on the phone, just like all of our patients do. And so ultimately, in the end, it was great because we were able to talk by phone and kind of go through all of the things she had attempted. And here is what we can do. Here are the 2 things that we need to get together in lieu of her birth certificate. And I walked her through how we get those documents. And we went through the links together and mailed her information, and heard from a care manager today at a local Catholic charity that the family's been working with. And now we're teaming up together to help grandma because he can help in different ways than I can. And so we're almost there. We're one step away from getting Medicaid, but just that simple Medicaid acceptance, getting that insurance is truly actually life changing for this child who has gross caries, who is waiting to actually be able to go to the OR to have his procedures done. And that's a very expensive trip. So thinking about Medicaid that would cover the cost of these procedures, and we've got grandma who otherwise is going to have to find a way to pay out of pocket when she's working full time and caring for her 2 grandchildren independently. It's a big challenge. And that's a great patient, Laura. You asked me about follow-up care, who once we get done with this, I'm going to have a whole different conversation with grandma just to figure out what else is missing. What are the other barriers? What are the other resources that we need? What is not what needs are not being met. Because if they don't have Medicaid, it's also likely they probably haven't seen a pediatrician in a while. It may be likely that they don't have all their vaccinations up to date. There may be food insecurity because they're not receiving benefits from the state, like SNAP benefits that help out with nutrition services. So I do a little bit of a larger umbrella of an assessment after we kind of put out this more emergent fire.
That's a great story. I think it really goes to show that it takes a village to overcome these barriers. Like you said, grandma, the interpreter, the charity, and then you as, frankly, the quarterback kind of getting everything together and coordinating a lot of these challenges with these other folks. So I think that's really great.
And I thought of one more too, if you want one other that's a little bit more brief. So one of the most interesting experiences I've had in my short time at the Adams School of Dentistry was one day I got a call from a dental student saying, I've got a patient in crisis, and I need your help. And so uh, this patient presented to the student after I think only one other visit, actually. So there wasn't a whole lot of rapport that had been built, not a whole lot of time spent together, unlike some of our other students and their patients have been together a year or two at a certain point. And so with one visit under her belt, this patient shows up and says, I'm actually scared for my life. I am really concerned that my husband is going to harm me. And so the student gathered a little bit of information and called in the social worker, which was completely appropriate. It was a great example of what people don't think is going to happen in the dental world, but it does, because this patient specifically was from a county that's a few counties over, and for the first time in months was in an environment where she felt like no one knew her situation, no one knew her husband, and no one knew her. And so she laid back in that chair, and the first thing that came out of her mouth was, I need to talk with you about this. She felt like she was in a safe environment. Even though she didn't know that student very well, she had some physical safety of not of being removed from that county. And so we were able to kind of bring her, out of that open operatory space into a room with a closed door and have a conversation with her about her safety, what was going on, what were local resources that we needed to work with, domestic violence agencies, law enforcement, and create a plan to make sure that she felt safe leaving that day. And it was also a great example of a really difficult choice that dental providers have to make, which is to just call a timeout on the procedure that was happening that day. And the student said, pretty quickly, I knew we weren't going to get any dental work done today. And those are the exceptions, Laura, where the 5, 10, 15 rule doesn't really come into play, where we have to, as a team, say, what's our priority today? Is it dental work, or is it making sure that this person is safe to go home?
I think that's a great resource because I know during my residency period, there was a child who had come forward with his provider saying that he didn't feel safe with one of his parents. And as residents, we didn't really know where to refer them other than Child Protective Services, which wasn't exactly the first person we would want interfacing in that situation. And so it's good to hear that there's another resource in the building to help with situations like that.
And Laura, it's such a great example of where I've seen social work flourish in a setting with learners and even with faculty, even with experienced faculty members. Um, a part of my role is being a consultant in that way. And so even if there's a situation where I don't need to talk directly with a patient, or a patient isn't present at that moment, students, residents, faculty members can call me, can message me in Epic, they can email me and say, hey, I'm doing this chart review and I don't know how to ask this question. I see a long history. I got an Epic message the other day from a student who said, I'm going to see this patient for the first time, and they have a really long history of assaults from their partner that are showing up from the local emergency room, because now that we're on Epic, we can see all of UNC's records. And so with that knowledge comes a lot of power and a lot of responsibility. Do I bring this up? Do I not bring this up? Is it relevant to care? Is this something that I should ask? And if so, how? So having those conversations to empower people, because one of the questions I get most often is, what do I do when I'm in the real world and I don't have a social worker? And it's a perfectly legitimate question. And so if I am constantly coming in and taking over, that patient visit and that conversation and having those difficult conversations myself, you're not learning how to have any difficult conversations as a provider. And so my answer to students is that my goal is by the time we work together, even just with a couple of patients, that you sitting in the operatory with me, hearing those 3-minute, 5-minute conversations, 10 or 15 if need be, that you're going to gain some skills. You're going to gain some of those clinical skills. You're going to glean some information about how do I frame difficult questions? How do I ask questions about quality of life? How do I ask questions about safety? And how do you have those respectful conversations with people? And you're going to take those skills with you. And I've seen it happen. I've seen students say, wow, okay, I know how to ask next time about a person's preferred pronouns, or I know how to have a conversation with them about the value of taking care of their chronic disease, or I understand a little bit more about how the mental health system works in North Carolina, so I can at least give that explanation and see if they'd be willing to talk with you about connecting with a therapist.
Yeah, thanks for sharing those examples. That's really helpful. And that just goes to show that, as you alluded to before, Jamie, dentistry is so much more than teeth. And that's a lot of what we focus on, and I'm guilty of that on this channel. But seeing patients regularly, at least twice a year, in dentistry, means that we have potentially more opportunities to run into these kind of situations. So, which is why I think it's so important to be exposed to this side of dentistry, and why I think it's so great that you're joining us here.
Absolutely. And it has been really eye-opening for me to be so new in dentistry, because as soon as I came in, I thought this is really of all the healthcare settings that I have been in or been able to just interface with, this is the most technically skilled setting that I've been in. And these providers are there's no doubt that they care about their patients. But I also found, on the other hand, that even though this is a very intelligent group of people with an amazing skill set who cares deeply for their patients, that I was butting heads with trying to get people to understand why we should look at the whole person and why we should look at this very big global view of our patients from a community perspective, from a global health perspective. And finally, a dear dental colleague of mine said, Jamie, you have to understand, we are trained to look at patients in a millimeter viewpoint. We are technically skilled. This is what we do. We look on this micro level and we focus in and we take our time. And you are asking people to step back to 100-yard viewpoint. And so my basic knowledge of human behavior had gone out the window for the first few weeks at the dental school until this colleague explained this to me. And I thought, oh my goodness, of course, if you ask anyone to take a 2-millimeter point of view and take it back to a 100-yard view, that's going to be really challenging. That's a complete culture shift and it's a completely different way of doing care. And so it has been a lot of working together for me to understand dentistry, for dentistry to understand social work, and for us to figure out exactly how we can come together to improve treatment outcomes for patients and quality of life, but also to make the dental professional's job a lot easier. It reduces burnout when you have a social worker on your team. It helps you to save a little bit of time in some situations, save some pain when you have, reduced no-show rates and you have patients whose depression is actually being treated and their anxiety is a little bit less. There's so many benefits, but it is a big, big culture shift that takes a lot of time and understanding.
In our practice, we sometimes joke that we wish we had a psychiatrist on staff to help manage certain patient interactions because it seemed like the visits were not about the dentistry and
Mhm.
I'm also an orthodontist like Ryan and not about the teeth straightening but very much about other things, but we were just talking about teeth as a surrogate for something else. And so I could definitely see how that would be beneficial to have someone to actually address the underlying issue.
Absolutely, absolutely. And it has been just phenomenal to see how the teeth are messengers for so many things that you really wouldn't know about otherwise. And these are things I didn't know until I came to the dental setting and thought, oh my goodness, things like eating disorders that otherwise are really, really difficult to screen and identify in primary care or in other healthcare settings, they're extremely evident in the dental setting. And it's even more evidence why social work or having a mental health professional on the team is so important. And when you said that, Laura, I was thinking you were going to say for you all, because I've gotten that message from people too, is so
It
you're
would
here
help
for the
us too.
patients. We're here for the patients, but who's going to be here for us? And I think it's such a good point, is that we're all, there are just so many different dynamics going on when we interact with patients. And so having someone on the team, at least to support patients, is really critical.
The teeth are messengers for so many things. I think that's a great message to end on. So thank you again for joining us today, Jamie. We both learned a lot, and I know our listeners will too. So we really appreciate you taking the time with us today.
Absolutely. Thank you so much. This was so wonderful. I really enjoyed it.
I love Jamie. That's one of the most uplifting interviews and conversations I've had in a while. What was your favorite part of the interview?
Yeah, she was so positive. I just loved her outlook on kind of focusing on truly helping the person, like meeting them where they're at. I really liked her explanation of motivational interviewing. It's kind of an abstract idea, but she made it very practical. I never thought about opening a smoking conversation with, well, what do you like about smoking? Or what do you love about smoking? And then guiding the discussion from there. That was really cool. I also liked her perspective on holistic patient care, taking a big step back from our often millimeter perspective. And I feel like I have a much better idea of what social work is, of focusing on the patient as a person and the environment in which that person is.
I agree. And going into this episode, I was a little bit dubious about the concept of social work and dentistry. And now I have a much better understanding of why that would be of value, especially in contexts with lower socioeconomic status patients where they have many unmet needs. And this is a good point of care and point of access to those populations to be able to help them not only get dental care but all of their other needs met, whether it's medical care or food or social services.
Yeah, exactly. And I hope we get to the point one day where a social worker is an essential part of any dental practice, where if they're not on site, they're at least a phone call or an email away, where a dental professional could easily reach out to a social worker to serve as the quarterback for, smoking cessation or Medicaid approval or an abuse neglect situation. I think having those resources available is so important for a patient to be treated completely.
Absolutely.
Cool. Well, thanks so much for listening, everyone. Laura and I had a lot of fun with this, and we'll be back again soon with another episode. But for now, take care, be safe, and we'll see you all in the next episode.